Hello, everyone. Thank you for coming. Welcome to NADO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendees screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NADO's Executive Director. Norm, the stage is yours.
Thank you, Erica. It's so wonderful. It's been a wonderful 3 days for all of us here at NADO. We've appreciated the massive participation, the large numbers of people asking questions and comments in the chat, and we're just thrilled to have you with us. Sort of a bittersweet ending to our conference. We've got some of the best presentations saved for you for our closing plenary. This session is going to be Mission Possible, Reducing Healthcare Disparities, Rethinking Drug Use, and Rewriting Diabetes Care. This session was organized by Angela Taylor from the Kentucky Cabinet for Health and Family Services, who will also serve as our moderator. So Charles, let's go ahead and bring Angela on stage. Angela, I'm going to turn the stage over to you.
Hi, good afternoon. All right, bear with me just a little bit as I lean into this title, and I might even be a little cheesier than normal. But with that said, good afternoon, everyone, and welcome to Mission Possible. Today, we're on a high-stakes mission, tackling 3 big challenges in healthcare: reducing health disparities, rethinking drug use, and rewriting diabetes care. These are critical issues that affect countless lives, and we're lucky to have a lineup of experts here to guide us through some exciting work happening in these areas. I'm Angela Taylor, your moderator for the session. Together with our speakers, we're going to explore fresh ideas and approaches to make meaningful changes in healthcare. We'll be hearing from a diverse team of professionals, our field agents of healthcare analytics, who are breaking new ground on these issues every day. They've come armed with insights, innovative strategies, and the lessons they've learned. So as we go through the presentations, don't hesitate to jump in with your questions. With that, let's get started and meet our first agents. Our first agents are Princess Collins, her codename, the Quality Commander, and Jason Mazique, his codename, the Population Protector. And their mission, incentivizing reductions in health disparities through hospital pay-for-performance programs. Could we bring them on stage?
Hello, I am Princess Collins, the Chief of Quality Initiatives, and here with me today is my colleague Jason Mazique, the Chief of Population Health, and we are both from Maryland's Health Services Cost Review Commission. Today, we will be presenting on how Maryland's hospitals are incentivized to reduce health disparities through our hospital pay-for-performance programs. The Health Services Cost Review Commission is the independent state agency in Maryland, which is responsible for regulating the quality and cost of hospital services by establishing rates. The commission establishes hospital and service-specific rates for all Maryland hospitals while ensuring that rates are set equitably among all purchasers of hospital services, meaning that all payers pay the same price for the same services within a hospital. Given the role of the HSCRC, it is clear that we have a unique healthcare system here in Maryland. The Maryland Health Model is comprised of 2 main parts, the first being the all-payer rate-setting authority that was given to the HSCRC through the Maryland State Legislature in 1971, and the second is the CMS and Maryland Agreement, which allows hospitals to be placed on global budgets, for Maryland to be able to adopt new and innovative policies aimed at reducing hospital expenditures and improving health outcomes, and allows for Maryland's exemption from the federal Medicare quality pay-for-performance programs. This exemption allows Maryland to create our own quality pay-for-performance programs, which we'll get into on the next slide. Here, we have listed Maryland's pay-for-performance programs. These programs are modeled after the federal Medicare Quality Pay for Performance programs, but our programs are all payer whenever possible and are tailored to address Maryland's unique needs and quality improvement strategies. Today, we're specifically going to focus on the Readmissions Reduction Incentive Program and its disparity component. Maryland's readmission program incentivizes hospitals to reduce 30-day, all-cause, all-condition, all-payer readmissions by holding a percentage of a hospital's revenue at risk for a reward or penalty. The readmissions program is Maryland's analogous program to the Medicare Hospital Readmission Reduction Program, but it has an all-payer focus instead of focusing just on Medicare readmissions. Other differences include Maryland's program assessing readmissions for all conditions, while the federal program assesses readmissions for only 5 specific conditions. And further, the Maryland program provides rewards and penalties based on how hospitals perform relative to our preset targets, while the federal program only provides penalties and relatively ranks hospitals to determine which hospitals will be penalized. Here, we just wanted to note how Maryland has performed at reducing the statewide readmission rate. In calendar year 23, Maryland had a target of reducing statewide readmissions by 7.5% when compared to 2018. As this graph shows, we didn't exactly hit our target, but we reduced readmissions by about 6.5% in 5 years, with some hospitals hitting and surpassing the 7.5% reduction goal, which we set. Seeing progress on our general readmissions measure and with the nationwide focus on reducing disparities, we have created a disparity gap component of the readmissions program, making it the first statewide program in the nation with a financial incentive for reducing disparities in all payer readmission rates. Through this reward-only program, the HSCRC rewards hospitals for reducing disparities in readmissions related to race and socioeconomic status. Over the past 3 years, Maryland hospitals have been rewarded about $19.6 million for reducing their disparities in readmissions. I will now turn it over to Jason to explain the development and measurement of the readmissions disparity gap program and its 2 components.
Good afternoon, everyone. Before we jump in, we just wanted to acknowledge that there is a large and established body of research that shows the connection between certain social risk factors and readmissions rates. You know that these include prescription drug coverage, access to outpatient care, and financial stress, among other factors. However, with regards to both the national profile and the state of Maryland, we know that 3 social variables are particularly correlated with readmissions rates. We know these to be racial status, Medicaid status, and area deprivation index. For those of you who don't know, area deprivation index is a geographic measure of social deprivation based on zip code. So before jumping into the rest, I just wanted to establish that these are 2 separate but interrelated statistical models. The patient adversity index is based on a multivariate regression model that estimates the association of readmissions risk based on area deprivation index, Medicaid status, and the Black race. We chose to employ a composite measure to provide an actionable, easily cohesive metric that is easy for hospitals to understand. And we chose to employ a multi-level model to better approximate the accuracy of the PI scores and account for hospital grouping. In essence, a larger value corresponds to a higher social adversity, and PI scores are normalized so that the statewide mean is 0, and each 1-point change in the scale represents a change of 1 standard deviation. So coefficients from this regression are used to calculate a PI score for each individual discharge, and patient-level PI scores are recorded in the HSCRC all-payer case mix dataset and collated by hospital level on Maryland's Health Information Exchange CRISP, which my colleague Princess will describe later. So moving into the within-hospital disparity gap. The within-hospital disparity gap is calculated by a second statistical model that incorporates a hospital's PI scores. First, the multi-level model estimates the slope of the line connecting readmissions rates at various levels of PI within a hospital. I've included this graphic here to the right to illustrate that point. A flat slope would indicate that there are in essence no disparities. The readmissions risk is the same as PI equals 0 and PI equals 1. Conversely, a steep slope would indicate very stark disparities. Therefore, a reduced slope over time indicates that a hospital is making progress in eliminating those disparities. The yearly disparity gap is equal to the risk-adjusted readmissions rate at PI equals 1 minus the risk-adjusted readmissions rate at PI equals 0. So the goal of this program is for hospitals to reduce their slope or the disparity over time while not increasing or backsliding on the 30-day readmissions rate measured in the general RIP program. The difference between the performance period and the baseline period corresponds to the disparity gap improvement compared to the 2018 baseline. So important to note is that revenue adjustments are currently reward only. They're scaled to begin at 0.25% of inpatient revenue, and they're capped at 0.5% of inpatient revenue. We've included this table here below to indicate the three latest calendar years, the number of hospitals rewarded, and the statewide pie revenue adjustments. I'll now hand it back to my colleague Princess to describe the disparity gap reporting.
Through Maryland's Health Information Exchange, which is Chesapeake Regional Information System for Our Patients, or CRISP, we are able to provide hospitals with performance results for each of our programs and all of the measures within those programs. Each month, via CRISP, the HSCRC provides hospitals with the performance in the Readmissions Disparity Gap program on a summary and patient level. The top picture shows the summary level report, which allows hospitals to glean the average pie at all Maryland hospitals and how each hospital has performed year to date at reducing disparities in readmissions from 2018. This summary level report also provides hospitals with readmission rates for each of the pie components. So for example, hospitals can see their readmission rates for their Medicaid population versus their non-Medicaid population, and the same for low and high ADI patients and Black and non-Black patients. The bottom picture here shows the patient level reports, allowing hospitals to see which of their patients are contributing to the disparity gap, allowing a hospital to intervene with those specific patients. In the screenshot here, you can see that each of the components of a disparity gap program are provided for each of the patients. So each patient has their payer, race, and ADI percentile. The goal of both of these reports is for hospitals to understand where their area of opportunities are and how they can intervene. We are committed to incentivizing hospitals to reduce their disparities, so we've applied our disparity gap model methodology to another measure called the timely follow-up after acute exacerbations measure. This measure is a part of our quality-based reimbursement program due to the drastic disparities in timely follow-up for payers, ADI, and race. We will continue to stratify other quality measures to understand the disparities experienced by Maryland patients and determine if the disparity gap model is appropriate to reduce disparities that are uncovered. We are also proud to announce that we are moving into a new model with CMS called the State's Advancing All-Payer Health Equity Approaches and Development, also known as a HED. Our disparity gap methodology aligns with the health equity focus of this new model, and we're excited to potentially expand it.
We would like to give a special thank you to Dr. Allison Schuster and Dr. Jeff Doherty for their leadership in the development of the Patient Adversity Index and the Within Hospital Disparity Gap. Thank you all for attending our presentation.
Really great presentation, guys. I'm going to take privilege as the moderator and ask a quick question. If you remember off the top of your head, do you know how long it took for the first hospital to start receiving a reward?
So we provide rewards year over year. So the first year that we implemented this program, a hospital did receive a reward for this when comparing back to 2018. And the first year we implemented this for revenue adjustments was 2021.
That's excellent. As we're waiting for the audience to put their questions in the chat, I do have a couple more for you, if you don't mind. Again, taking moderator privileges here. Are hospitals with disproportionately high levels of highly adverse patients, thinking Medicaid, at risk of not receiving a reward under the disparity gap policy?
Yeah, great question, and I can hop on that one. So the Patient Adversity Index model, as well as the Within Hospital Disparity Gap model, they are adjusted for not only APR-DRG, which is a reflection of sort of patient risk itself, as well as age and gender, but they're also centered on hospital mean pie. So that means that hospitals are not penalized necessarily for having an imbalance with regards to their patient population. So that model actually accounts for that, and that's something that we sort of work towards as we develop the model to make sure that hospitals in particular with those high abundance of, in that imbalance of high pie patients were not adversely penalized.
Catherine has a question for you. Have you had to combine years of data to ensure model stability when producing risk-adjusted rates by hospital due to low volume of discharges, especially when stratified?
Yeah, I can take that one as well. So with regards to hospitals that have had low volumes, we both have been able to benefit from sort of the multi-level nature of the model that accounts with shrinkage with regards to sort of estimating that slope for low volume hospitals in tandem with, again, combining years of data. So that kind of goes back to our original intention of using a multi-level model that would approximate and better capture the accuracy with regards to the statistics of it all.
Okay, great. Thank you. Thank you, agents. I really enjoyed your presentation. I'm going to move on to the next one. We'll come back at the end if we have additional questions for you in the audience chat.
Thank you.
Thank you.
So if you were lucky, you may have seen our next agent present yesterday. Our next agent is Joe Wozny, the utmost. His mission, from HEDIS guidelines to digging into drug data, investigating GLP-1 prescribing trends. Joe?
Hello, my name's Joe Wozny. I'm from the Center for Healthcare Data. We are the administrator for the Texas APCD, and I'm going to talk about GLPs. So maybe about a year ago, Dr. Kraus, the co-founder of the Center for Healthcare Data, came to us with some really weird data that showed some very high prevalence rates for diabetes, and we were using the HEDIS 2023 guidelines, and we were like, well, she said, what's going on with this? And we looked through it, and at the time, you could be considered someone that met the diabetes measure if you had any RX claim of the drugs on the list. And so we looked through the list, and what do you think we found? Well, we found Ozempic. So we decided, why don't we start digging into our various claims, data sources, and seeing what we find to get a better hold on this issue, which I'm sure will continue to be an issue for a while. So just some quick terminology. Glucagon-like peptide-1 receptor agonists, which I will just call GLPs, are medications. You probably know Ozempic or Wegovy more likely if you've seen any advertising, which stimulate the production of insulin and appear to reduce appetite, slow digestion, increase metabolism, and as you'll hear in another presentation in our session, many more things that they are interesting for. Just a preview, we found a surge in prescriptions, which should surprise no one. The rise of semaglutide in particular versus other types of GLPs, since semaglutide is one type of GLP. We saw a shift in prescribing patterns from primarily diabetic users, those who had diabetes ICD codes or other diabetes drugs, to more non-diabetic patients who didn't have those indications. And we looked at the differences between the groups. They're different by age and sex. And we also found an interesting group of GLP users that had neither diabetes indication or codes for obesity or overweight. So that's the head scratch group. About the data, we used Meritive market scan data from 2018 to 2022. We used both the commercial and the Medicare Advantage data sets. We restricted everything to 18 plus. It's descriptive analysis at the yearly level. So off the bat, there was a fourfold. If you look at this green line at the top, this is the population prescribing rate. So everyone who had a GLP divided by everyone that was enrolled at some point in the year in the Meritive data set. So there was a fourfold increase in the GLP prescribing rate from 745 to 2271 per 100,000 in 2022. Now semaglutide increased 22-fold from 54 to 1200 per 100,000 across 2018 to 2022. So an enormous increase for semaglutide. And if you kind of add together the orange line in the middle and the purple line at the bottom, you can kind of see that semaglutide, really drove the increase in overall GLP trend increase. So we wanted to break this down. So we took all GLP users. We took the first GLP RX claim they had of the year, and then we assigned them to the drug, and then we looked to see, do they have diabetes indication? Diabetes indication meaning that they have an ICD-10 code for diabetes, or they took other drugs that were on the HEDIS list like insulin. So either of those would, within a year before the GLP, would give us diabetes indication. And then we further broke it down into obesity or overweight or no obesity or overweight using some previously published mappings from ICD codes to obesity or overweight status. So this is just a breakdown of our subgroups. Like I said, there was an interesting group. So if you look on the right red bar, the smallest group of them all, this is the mystery group. So they have GLP claims, but they do not have diabetes indication, and they do not have any ICD codes for obesity or overweight. So this group has kind of had us scratching our heads. It's more interesting if we look at the groups over time, so this is out of all the GLP users. What category do they fit in terms of whether or not they have diabetes or whether or not they're overweight? So around 2021, the group composition starts to change, where those with diabetes indication and obesity or overweight indication go down, while overall the group with no diabetes, both overweight or not overweight, rises. So like I said in the beginning, over time, the composition of GLP users changes, where there's less with diabetes indication, and more without diabetes indication. And like I said, we're trying to figure out, well, what's the difference between these groups? And the two things we found, the first one is that age is different. So this is just a density plot of age. So these two curves on the left are the no diabetes groups, which, as you can see, have kind of a younger distribution than the diabetes indication groups to the right of them. We also found that there was differences in sex. So for the diabetes indication group, it's a little more evenly split between male and female, whereas the non-diabetes group, so those that didn't have an ICD code and they didn't take insulin or other drugs related to diabetes, were predominated by females versus males. So those were the two differences between these kind of groups that we found. What about brand names? Well, as you could expect, there was an overall rise in Ozempic over time, whereas Trulicity, which is dulaglutide, so not a semaglutide, fell, and as well as Victoza, which is liraglutide, fell over time. And again, we break this down into our subgroups. So the top two line graphs are the diabetes indication group, which seem to fit that same pattern that we saw in the overall, since most of the people in the population are in the diabetes indication. And then the distribution looks different for the no diabetes indication group, where you see that Saxenda falls over time as Ozempic and Wegovy. That Wegovy is that purple line that's popping up, and then Mounjaro wasn't on the scene until much later. But so the difference in brand name distribution is not necessarily tied to the overweight or obesity status as much as it is the diabetes indication status. And then we tried to look at, is there evidence that maybe someone was getting a diabetes diagnosis code in order to get medication? So we thought that, so for everyone that had a diabetes ICD code, was it getting closer in time to the medication time? And so we looked at the percentage of those whose DX was less than 30 days prior to their GLP date, and it actually it was less than 5% the whole time. There was a small rise, but it wasn't anything to give us strong evidence that, okay, well, maybe they're just adding this DX code in order to get onto this drug. We also looked to see if those without diabetes got the diagnosis within 90 days, like maybe we were just missing it, and it was still under 10%. For most of the time, but the percentage rose, but it remained under 10%. So we're fairly confident. We caught most of the people that did have diabetes indication in the claims. We also looked for abnormal glucose or pre-diabetes DX code before. It rose over time, so we thought that maybe that would be an indication of why these drugs were being prescribed. So this is only out of those who did not have diabetes indication. So over time, more of those people have abnormal glucose or pre-diabetes DX before, but it remained below 30% the entire time, although it did rise. So just to review, we saw a surge in GLP-1 prescriptions, a 22-fold rise in semaglutide. We saw the market share dominated by Ozempic over time across all of our different subgroups, be they having diabetes indication or no diabetes indication. We saw more GLP users without indication of diabetes after 2021. So that's kind of when the composition of GLP users really started to change. The main difference was between the diabetic indication and not diabetic indication. And the way that those users differed was by age and by sex. And also that it was hard for us to find evidence of a DX being added for the sake of having access to, the weight loss usage maybe of Ozempic, since it wasn't approved at the time for that, they might, add the DX to get that. Our present and future steps, as of 2024, the HEDIS guidelines have been updated to correct the issue with the 2023 guidelines. So that has been fixed. People do need to meet other measures to be considered that. They can't just be considered diabetic because of a GLP claim. We've put our findings together into a manuscript that we've submitted to the American Journal of Managed Care. And we've also started including GLP reporting in our state agency reporting, breaking it down by these same groups, those with diabetes indication and those by overweight and obesity status. And I think these stakeholders are just kind of watching it to see where it goes, and we're trying to decide, how we want to report these things going forward. But everyone's interested in it, and, we're happy to report on it and find ways to better report on it in the future. Acknowledgements, questions, check us out at the Center for Healthcare Data. Thank you to my collaborators, Dr. Trudy Millard-Krause, who's a co-founder and professor at the Center for Healthcare Data, Maria Nova, and Dr. Chao Trong. So thank you, everyone. Any questions? I can't hear right now.
It's because I'm on mute.
Oh, okay. All right, we're good.
Yeah, great presentation. Your code name is a little bit of a visual joke rather than a verbal one, so it's the utmost because you're at UTHealth. So
Right.
Just to clarify that for the audience. I have a question for you. We've done something similar to this in Kentucky with Medicaid data, and we noticed that, or we know for a fact that semaglutide is prescribed a lot more often simply because of the cost. So I'm wondering if you have or have plans to look at the cost variable within your analysis in the future.
I think that is on the agenda, and I think it kind of depends on who we're reporting for. As we've kind of like on the APCD side, we've started to figure out how we're making sure we get our costs right, and for other projects, for like state agency projects where we've had more time familiar with the data to get costs. So I think that's on the agenda, and we're just figuring out what it is. But yes, so that is on the long-term agenda to report those measures as well.
I have another question for you. So I know that you said it was less than 5% that got a DX within 30 days of getting their first prescription. Again, have you or do you have plans to look at the different providers that fall into that category?
The different providers?
Yeah, provider types. Like, is it?
I think that's a good next step. I think that oftentimes going back to look at provider type is helpful. I think I found a lot of times when we look at, like, sometimes there's a prescribing provider field, and it is usually like really, really null, like 60% of the time, and then you go back and you try to impute it by looking at, well, what was the provider that they saw most recent in time, and you get a lot of mixed results. So in my experience, I've had some kind of mixed results trying to look at it, but I definitely think that that is something we can try to glean some information for, and you're kind of limited by this specific specificity of the taxonomy codes and how much you can learn. But I definitely think that would be another good next step to look at.
Yeah, that's extremely interesting. I kind of want to steal that idea to see if that's happening within our data set. Thank you so much. I'm going to move to the next presenter,
Great,
and we'll come back if you have additional questions. All right, and for our last presentation of the day, we have our agent, Ernie Shippey. His code name is the Vizient Vanguard. Ernie?
Hope everybody's having a good day. My name is Ernie Shippey with Vizient. I'm a research director, and we're here to talk about the expansion of diabetes therapies across various specialties. In the last 3 years, 2 diabetes drugs have really increased therapies across both inpatient and outpatient therapy. GLP-1 drugs used for glucose control and SGLT2 inhibitors for glucose and sodium controls. So we see all these different specialty guidelines, American Diabetes, cardiology, kidney, obesity. They all have adopted these drugs to their guidelines within the last 3 years. But we wonder why. Well, the answer to this broad collaboration across specialties is really due to the fact that for diabetic drugs, they had a very checkered past. A lot of cardiovascular issues with these drugs as they try to control glucose, sodium. The largest one actually happened in 2008 when the Cleveland Clinic noticed that there was quite a bit of heart failure mortality compared to people not on these drugs. So the FDA in 2008 created a higher standard for these drugs to be used. And this higher standard required longitudinal data to look at cardiovascular mortality, all-cause mortality, impacts on the heart, impacts on renal failure. And they really got expanded because what clinicians found was with this extra data, this longitudinal data, they could look at the whole body system, not just looking at glucose control or metabolic issues. They could actually look at cardiovascular, renal, kidney protections, etc. A little background on some of these drugs, the GLP-1s, also known as the tides, semaglutides, liraglutides. What's really interesting about these drugs is that they have cardiovascular benefits, weight loss, A1C reduction, blood sugar control, and we see that they're very fast acting. We see within a matter of weeks, we start to see improvement with these drugs. The SGLT2 inhibitors, also known as flozins, these are very interesting because part of the mechanism is it allows the prevention of reprocessing of extra sugar and glucose into the body through the organ systems. And then that helps put less stress on those organs involved in that process. And so we start to see really great measures around blood sugar control, minor weight loss, blood pressure reduction with the sodium reducing. And we see, once again, we see very fast acting drugs and protection to the kidney, the heart, and the other organ systems. To look at these drugs, we used the Vizient clinical database. We looked at adult inpatient admissions from 2020 through 2024. We excluded pregnancy and newborn admissions. And then we focused on 2 different DRGs, heart failure and then heart transplant. And then in the multivariate model, we accounted for 38 comorbidities. And then we accounted for age, insurance, sex, race. And then we created a variable if the patient was on an SGLT2 inhibitor or not during their stay. As you can see in these graphs, those not receiving SGLT2, we see a much higher mortality rate than those on it, even during the early pandemic periods. The heart failure multivariate model, once again, we looked at the outcomes, and we can see a 57% lower mortality after adjusting for all the different demographics and comorbidities. Another thing that's really interesting is just the overall adoption. We can see in 2021, 520% of our hospitals, or 49%, were prescribing the SGLT2 inhibitors. And now we see a 93% rate in 2024 of our hospitals treating heart failure patients. For me, the really interesting one is really with this heart transplants. Very complicated case. We can see those on the SGLT2 inhibitors. We see a big difference, especially in the post-pandemic period. We see a larger and larger gap of inpatient mortality with these. Once again, with the heart transplant model, 54% lower mortality. A big difference is while the ACC, the American College of Cardiologists, added SGLT2 inhibitors to their guidelines for their heart failure patients. They don't control heart transplant guidelines, and those haven't been adopted by those agencies. But we see this large gap just emerging. We see in 2021, there was a pretty big gap, 10% versus 5%. Now in 2024, we see 21% mortality versus 7%. Another study was to look at GLP-1 prescribing patterns. For this one, once again, we used the Vizient clinical database. We linked it with the CDC's PLACES data set, and we looked at patients with type 2 diabetes and their role of GLP-1 prescription patterns within that zip code, same time period. And then we looked at just what were those patterns and associations. So here we have a map of the United States showing quite a bit of the variation in prescribing patterns over this time period. So we see there's certain regions that have really adopted it. So California, can't see on the map, Alaska, very high rates, Massachusetts, Vermont, very large usage there. But then we see some areas where it's almost non-existent, like Arkansas, a lot of times in the sweet tea, diabetes belt, we see there's still quite a bit of variation and opportunity to use these drugs. So some of the associations we saw with the GLP-1s, so we noticed that different populations based on zip code had higher prevalence rates. They had higher GLP-1 prescribing rates, which makes sense. Those providers are really working with populations where type 2 diabetes is very high. We also use Vizient's vulnerability index for social determinants of health. And we saw the ones that are least vulnerable, the wealthier zip codes, have much higher GLP-1 prescribing rates. We also looked at commercial versus Medicaid, and we saw that the commercial patients had about a 2.6 higher rate of GLP-1 prescription. Once again, we found these associations for these different states with the higher clusters. And then we saw cardiologists, endocrinologists, and nephrologists, those who work with the heart, metabolic issues, and the kidney, had the largest GLP-1 prescribing rates. So just a summary, the adverse events that had traditionally happened in diabetic medicine really created this higher standard. And then that gave us really rich data that allowed a lot of these different specialties to expand upon the cardiovascular outcomes trials. So they expanded to look at dialysis. They started to look at renal failure. So they started to see these protective nature of these drugs with this really rich data that we just didn't have before. And we saw a lot of new things happening. One that was really interesting was at the kidney conference. They actually had cardiologists there to talk about the fact that they're both prescribing these drugs and that they need to probably unify those guidelines together. Usually you don't see specialty organizations with this type of collaboration, which just shows you how this really enriched data, longitudinal data, really enables this collaboration that we're seeing around here. There was a really neat article in Nature on the SGLT2 inhibitors on just how it could possibly delay dialysis by much as 11 years. And there are several doctors that are working in the endocrine field that really feel like if we get broader adoption to these chronic kidney, diabetic, obese populations, that we could possibly delay dialysis in this country for decades to come. Thanks for your time, and I hope you found this interesting. Yeah,
Hi. Hey, making sure that I'm not on mute this time. It's been a long day. I just want to clarify something. Your study was mostly just looking at SGLT drugs, but did you notice in your data that was there a large percentage of patients on both SGLT2 and GLP at the same time?
That's very interesting. We actually have a publication that's being reviewed for a journal, and we actually looked at a lot of the new providers, especially in cardiology and in kidney, but they're actually prescribing both of those. And you can see that in the guideline changes that they made in 2023, where they're now suggesting that as a frontline therapeutic use. So that's a really good question.
Great. If anyone in the audience has questions for Ernie, now's your time. Just as a reminder, this is going to be your last chance to get to ask these questions of these four amazing presenters, all of our great field agents here. I guess if we don't have anything specifically in the audience, could we bring the whole panel back on stage? Oh, here's a question for Ernie. Does your data contain individual level mortality indicator, or did you have to bring such data from external sources? Thank you, Rob.
Yeah, so on that particular study, when we were looking at the mortality changes for those two different DRGs, we were looking at inpatient mortality, so we did have the discharge status to enable that.
Welcome back, agents. We do have a couple of questions for you guys. I'm going to start with a couple that were from the audience for Joe. Lori Paxson asks, shoot, let me find it again. What about availability? I know Saxenda was unavailable for almost a year. Is that reflected in your data?
Yeah, that's a great question. I know there's been various shortages. I mean, the most recent ones from my memory about Saxenda were in 2023 and 24, which was after we had looked at the data, and I'm not exactly I don't quite remember what it was in 2022, but I mean, in the data at that point, I think Saxenda had already gone down, and maybe that it losing its kind of market share is just a reflection of people are switching to alternative drugs, and it made more sense to switch to them. But I think that's really something that I would be kind of interested in sorting out, is like, what was the actual demand on the market for these drugs that then drove what actually we see in the claims, which I think is a question of bringing in other data, whether aggregated or just as domain knowledge, to kind of inform what we're seeing here, aside from just the claims of like, how do we actually say what the demand for this drug was, and what the supply was, and how do we match that then to claims? So I think that's an interesting area to look at.
All right, and William Nelson has a question also for you, Joe. There's been some evidence that these medications can be effective in treating conditions such as addiction. Have you explored if these medications are being prescribed for that off-label use?
Yeah, I think that our initial interest was just to think of something as off-label, just as a kind of flat statement of it's off-label, and that the next step would then to say, okay, since we don't see this diabetes indication, how do we actually map that via, I don't know if it's a prescribing provider field, or just trying to kind of use their claims to make some statement about what kind of doctors they were seeing to say this was actually prescribed for addiction. So I think that's an interesting thing to look into, is like, is there a way that we could actually find the reason for some of these prescriptions that are off the label? So we haven't looked at that yet in terms of addiction, but I know that it's in the news and there's a lot of promise, and so I think it's definitely worth looking into.
Okay, question for Princess and Jason. Is it possible for hospitals to display improvement in reducing their disparity gap through increasing readmission rates among low PAI patients, not agents? You guys are agents.
So I'll take this question. So we're very specific about this and not wanting folks to, reduce, increase their readmissions to, being in this gap program. So what we've said is, to receive the reward, your readmission rate overall needs to be decreasing. So the only way to receive a reward is by having a decrease in your readmission rate, and then we look to see if you're reducing disparity gaps to provide a reward for doing so.
Okay, we do have some more questions for you guys. For Joe, Did you find downstream outcomes not related to diabetes or weight loss? For example, did GLP-1 develop unexpected gallbladder issues?
We did not look for those, but I think that this certainly seems like it will be kind of one of the various research questions that will all be bubbling out as people have all this interest in GLPs, is to like look for those sorts of things. So thank you for that idea. We'll see if that's something we're interested in looking at, but we haven't looked at that, but maybe we should.
Monica asks of the first presenters, of Princess and Jason, for the first speakers, were there specific conditions that hospitals report leading the number of unplanned readmissions? Separately, do hospitals report how they use incentive payments?
Well, I can't speak specifically to which, over statewide, which conditions lead to unplanned readmissions. And we do, at this time, we do not require hospitals to report how they use these incentives. We are requiring hospitals now to submit interventions that they have at their hospitals for reducing disparities in readmissions, to ensure that this is not just happenstance and that they are actively trying to reduce disparities in readmissions.
All right, and Denise asks the following question. Utilization disparities seem to be driven by type of insurance, public versus commercial. I'd like to add on to that particular question because I think it's for Joe. And I was wondering if you found disparities in the prescribing patterns of patients receiving GLP-1s.
Well, so we basically found, because we're using GLP users as our denominator population, that we're looking in from, that basically the group that is off-label, that was, mostly the younger fee on commercial plans. I think maybe I had cut that graph from my presentation to save on time, but the age maps straight on to, what you would expect their insurance coverage to be. So between those two groups, the ones that are off-label are the younger ones and on commercial plans, and those that have diabetes indication tend to be more likely to be on a Medicare plan. So not necessarily that they had higher utilization of GLPs, but they were more likely to fit into one of the type of GLP users.
What about any other demographic disparities?
Those were the ones we basically picked out that seemed to actually have differences, which is really age and sex, and otherwise. And then if you apply age then to insurance coverage, it's pretty similar. So I mean, there's very little coverage on Medicare. Very few people on Medicare had an indication of off-label GLP utilization. But other than that, we didn't find anything that poked out at us.
Okay. So, Ernie, I have a question that's sort of related to the unexpected gallbladder disease. Are there other health outcomes that you're hoping to study in the future based on the prescribing of SGLT?
One research question we're working on is we're mostly looking at dialysis, because we have data from CMS that we use, and we're noticing with these patients, when we did a 4-year study, was that the rate of dialysis is much different between those on GLP-1s and SGLT2s versus those that aren't on those. So we're looking at them more for the protective effects. I think because of the rich data that's required over the last 20 years from the FDA on these diabetic drugs, a lot of the safety issues, we just aren't seeing them in any of our data. We've run all the comorbidities. We've run a lot of different adverse effects. We're just not seeing it in the data. It doesn't mean it's not there, but once again, we're just not seeing it within the data.
Okay. Okay, for Joe, what's one aspect of GLP trends you wish you could tease out of the data that you aren't sure how to go about?
And maybe this isn't teased out of the data, but I think that you know it's such an important market thing because it's really changed the way that like the average everyday person gets drugs. Like you see all these people are just going out of pocket and buying these things. They're getting on hims.com. You're getting these third party things that are coming in and just offering this as cash and saying, you can talk to a doctor on telemedicine. You don't need to worry about your insurance, and people are willing to pay that cost. And that's like such a missing piece of what we necessarily have in the claims, because that's what we're used to dealing with. And sort of where does all that kind of fit into the picture? Because that's just like a wild west of the way people are starting to interact with drugs in general now, is these weird kind of third party, people get on Amazon and they sign up for Ozempic monthly and they're just going to pay cash for it. And like, how do we figure out how to fit that kind of market into the way that we report on drugs or think about drugs, and how does it affect our data? So I think that's something that I wish there was a way I could figure out how to kind of tap into those data sources and understand how that is affecting demand, supply, and the way people interact with their regular drug use that we see on the claims.
Princess and Jason, what's next for you guys? What's next on the agenda for this study?
So we've taken this this methodology and we've applied it to other measures. So at this point, we're stratifying our other quality measures to understand if this disparity gap methodology is applicable to reducing disparities in those other measures. And moving forward into HED and understanding how else, we can incentivize hospitals to reduce disparities. Jason, did you have anything to add?
Yeah, I think hopping onto that more methodologically, we've used the area deprivation index, and that's been really helpful as we develop the PI metric, but it's something that we're continuing to evaluate, keeping an eye on as we're thinking about how can we accurately capture disparities in the coming years. So that's an integral component of the methodology and one that we're continually evaluating.
Okay, this is a question for the whole panel. Do you have any closing thoughts you'd like to share with our audience?
I have a question for Jason. Maybe did you go through some like model development in order to decide upon this kind of multi-level modeling approach as the right way to measure this? And were there some earlier prototypes that you worked through before you kind of arrived at this solution?
Yeah, absolutely. I joined our current organization after the initial modeling had been set up. But to speak to that point, that Maryland is both a very diverse state, but also very sort of bimodal state with regards to sort of Baltimore and the Baltimore area hospitals and sort of the rest of the state. So in order to capture that geographic variation with regards to hospital usage, using that multi-level model and to account for that grouping added a lot of value that would be lost if we hadn't incorporated that multi-level model. So that's my understanding as to what it went into the initial derivation of using a multi-level model.
All right, I'd like to thank you all again. So now that we're closing out the day, I want to say thank you to our incredible agents for their insights and to each of you for your active participation in this vital mission. Today, we've come together to push boundaries in healthcare and tackle some of the most pressing issues of our time. As we close, let's remember that our mission doesn't end here. The work to achieve equity, improve care, and transform lives is ongoing, and each of us plays a critical role. And thank all of you in the audience. Let's continue making the impossible possible. Norm?
You're muted.
You're muted.
All right, now let's try that again. Thank you, Angela. Thank you, everyone. Thank you, Angela, for organizing. Thank you all for contributions in the audience. Just by way of summary, I think the conference has pointed out to me that while we all share this kind of common interest in collecting data, the ways that touches the world around us are almost infinite. Thinking about things like we had a discussion about maternal mortality. We've had discussions about GLP-1. We've had discussions about policy. We've had discussions about the technical aspects of data linkages, and so forth. It's just been incredible as to the variety of the things that you all are working on. We hope that this conference has allowed you to identify areas and people, more importantly, people that you can work with going forward. I do have a couple of concluding announcements for you. The first one, I know that there are 91 people who've been waiting for this announcement. 91 people have participated in the token hunt game, and here it is, the grand announcement. We just did the drawing a minute ago. The daily drawing grand prize winner is Betty Harney from Chia. She has won a $250 Amazon gift card in the token hunt game. So congratulations to Betty Harney. And hopefully all of you had some fun and learned something by doing that. The next thing I want to point out to you is, as you have heard many times, as much fun as it is to have a conference like this where we get to be somewhat in touch with each other, there's really nothing like being in the same room and being able to shake hands and and raise a glass together and even share a meal. So we are going to see y'all in Austin, Texas, May 6th to 8th, 2025. Pre-register now to save your spot at our in-person event. And we're emphasizing this. Last year, we were in New Orleans and we had anticipated 120 attendees. Our hotel had capacity for 150. We sold out of the 150 before early bird even closed. So we had a waiting list for the last little bit. Some of you will remember that, getting left out. Well, don't get left out this year. If you pre-register, you will be guaranteed a spot. We will make it work for you. So get pre-registered, even if you don't have formal permission from your boss, or even if you don't have all the things that you need to guarantee payment, get your name on that list, and then we can talk later about what we need to do to get you approved and get you in. So we'd love to see you there. Again, the details for pre-registration are at nato.org/conference. You can find that there. And we've also had a lot of questions, or the issue has come up multiple times. So what else? What else is going on? A lot of people are new to NATO, new to their jobs, don't really know what's going on. Charles and I have put together a complete list of all of our 2025 events, which include different types of affinity group meetings, webinars, you name it. It's all there. Again, so nato.org. If you go to conference, you will see a link for the 2025 schedule of events. Get those on your calendar so that you don't have those conflicts next year. I know there were some people that couldn't be here because of scheduling conflicts. Get it on your calendar now. We've got the dates for next year ready to go. So we're super excited about all of that. And again, if you know anybody who is not a NATO member who would really like to be a NATO member, thinking about that one, send them our way. We would love to be in touch with them about what that could mean and how they could participate in lots of ways. I do want to give a final shout out to both the NATO board, Angela and all of her colleagues on our NATO board, and Kenley, our board chair. Fantastic support to make this a great organization, and also our program planning committee. Again, we couldn't do this without all of the volunteers behind the scenes for all of this. So the presenters, the panelists, the planning committee, the board members, and our tech crew, everybody that's been involved. So thank you all once again. And we will see you. I'll see y'all, right, Angela? That's how we say that. See y'all in Austin next May. Thank you all.